Well, hello. This is Dr. Isabelle Amigues, and welcome to the UnabridgedMD Podcast. Here we explore inspiring stories, practical tools, and expert insights for living a healthy life. Whether you're a patient, a healthcare professional, or simply curious about healing, you are in the right place. And as always, if you are looking for something that's so much bigger than just a rheumatology practice, please come check UnabridgedMD, as we are the right place to get you to remission with the least amount of medication. With that said, let's dive in. Well, let's just jump right in. My guest today is a doctor in chiropractic. Do we say that?
Chiropractic.
Chiropractic. It's a doctor in chiropractic.
Mm-hmm.
Okay, yeah, you see. Something I actually didn't know existed until I moved to the US.
Mm-hmm.
So I'm really excited. I actually have the utmost respect for what you do. I think it's super interesting. And so without further ado, so this is Dr. Michael Lovich, mm-hmm. and we are going to go into what chiropractic care can help our patients with dysautonomia and POTS, among way more than just that. Thank you so much for being on the show.
Happy to be here.
Yeah. Okay, my first question, and you knew which one it was going to be, right? What is chiropractic care?
Okay, so it's a little bit of a complicated question because there's two schools of thought. Mm-hmm. Typically, most chiropractors, the thing that they all have in common is they have skills in adjustments. That's when you do like the popping that people see, like you see on YouTube videos or Instagram videos, cracking your back, that kind of thing. But that's how it started over 100 years ago. Since then, it's become more of a biomechanical analysis where a good chiropractor and a good physical therapist should look almost exactly the same. There are specialty degrees that you can do within chiropractic. So, for example, I have 2 board certifications. One is in sports medicine, and the other one is in neurology. So there's the American Chiropractic Board of Sports Physicians that they test chiropractors to say, okay, you are now a board certified sports chiropractor. And then there's the American Chiropractic Neurology Board, test that, and then you can see you're a chiropractic functional neurologist. So I do those together. So most cases that I work with are not your typical cases that a chiropractor will see, where they're going to more work on neck pain, back pain. Then you'll work with like regular sports chiropractors, and that's more extremities like ankle sprain, knee, hip, shoulders, that kind of stuff. My specialty also, I do a lot of neurological rehab with patients, which is what I did through that postdoctorate in clinical neuroscience.
Mm-hmm. Okay. So the science of adjustment, if I had to use 2 words, is that correct?
Yeah.
The science of adjustment with a hands-on technique.
Yep.
Okay. Amazing. And how did it start? Like, do we know the I'm sure it's a father, like the founding father. Tell me it's a woman. That would be amazing. I'm sure there's a woman that creates things. It's always a founding father, though.
Yeah, right?
We need to change that.
The history of chiropractic started back in 1895. Everything has its roots in something that, as science moves on, you continue to find new things to disprove old things.
Yes.
So back then, the person who invented the profession, D.D. Palmer, he was a magnetic healer. And then he found, and through some connections, he found that if you adjust certain areas, similar to what bone setting is, if you've heard of that, which has been around for a long time. And then also it's similar to how the original osteopathic physician also started with bone setting through AT still. Back then, it all started with, hey, if you pop a certain area, you might feel an improvement. There is a famous story that a lot of chiropractors continue to bring up, which is somebody had some hearing deficits. They did an adjustment in the back and the hearing improved.
Yeah.
And so, there's some more biological plausibility that explains a different mechanism than if you crack their back, everything gets better. But at the same time, a lot of people now do find relief from pain, or find improvement in movement, find improvement in like sports performance, or if they want to, if they are a recreational athlete.
Yeah.
People find benefit in a lot of different ways.
What got you drawn to it?
That's actually a funny story. So I graduated from college at the tail end of the 2008 collapse. And I saw that things were getting automated in a way that were, start off in the pharmacy world. Things got automated pretty quickly. People's jobs aren't necessarily where people had a lot of questions about jobs. And I was like, well, if I do something hands-on, then there's a good chance that won't get automated away.
Very smart.
Mm-hmm.
Do you think it's going to get automated or not?
I don't think that it can be, just based on the nature of the kinds of conditions we see. We usually see, at least in my office, we see so many more chronic conditions. We see so many more brain-related, especially like dysautonomia, like we were talking about earlier. We see more conditions like that. And those are most of the people who come to me. Those are the people who've already seen 19, 20 other doctors. If there was an algorithm to follow that was simple and clean like that, then sure, it could be automated. But if it was that simple, then I would feel like it would have already been followed.
Well, great segue to our next topic, which is dysautonomia and POTS. Can you share a little bit? Well, first, if you want to explain what is dysautonomia and POTS in layman's word, really, right? That's where I'm not necessarily the greatest, because I use like definition and so on, and that's not always helpful for patients. How would you describe what POTS and dysautonomia is? And then I really want us to talk about, what you can do for those patients, because they are really suffering.
So let's start with dysautonomia, because dysautonomia is more of a garbage bag term for everything and all diagnoses that fall underneath an error with your autonomic system. And for people who aren't familiar, your autonomic system is based off of, or built up by two particular systems, your sympathetic and your parasympathetic. If to get real oversimplified, sympathetic is going to be more of your fight, flight, freeze, things like that. Your parasympathetic is going to be rest and digest. Now, what I find, especially, you got a couple yoga classes, you watch some reels on Instagram, see on TikTok, a lot of people don't quite understand, or they're trying to personify these kinds of systems. And the reason why it's called the autonomic nervous system is because it's automatic. It happens in response to things. It's not just, I feel a certain way, so I'm going to do this with some sort of meeting. It's stimuli in the environment created a conscious experience that your brain translated and said, I should respond in this way as a reflex. And so one thing I'd like everybody listening here to think about is it's not a seesaw. You don't want to be all parasympathetic and not sympathetic. Parasympathetic creates weight gain. That's an idea of if you are all one and not the other, it's not all good. And I find that a lot of popular science, popular psychology is turning it into get away from sympathetic because it's your stress system, and go towards parasympathetic, which is your rest and recover system, which is not the fact. Instead of having this seesaw effect where you want to be all of one thing and less of another, I recommend everybody think about these systems as a thermostat, where if you have it set on 70 degrees, you want to jump from 69 to 71 and be tightly controlled between there, instead of jumping from maybe swinging to 60 and swinging to 80 and having these large swings back and forth. It's not necessarily a disorder of broken systems most of the time, but it's a disorder of dysregulation of those systems. And now this will cover things like syncope. This will cover things like
loss of consciousness, or falling, basically,
or like when you sit up too fast, or you stand up too fast, you start getting lightheaded and dizzy.
Yeah, it's good
you don't
for people to know that.
You don't even have to go to loss of consciousness. It could just be you stand up and you get lightheaded. That's not supposed to happen.
Yeah, totally.
And so when you go from there, or you can go towards the other direction of POTS, which is a lot of what I see in my practice, you're talking about your brain not perceiving where you are in space. And so when you go from lying to sitting or sitting to standing, you don't fire the appropriate reflexes to make sure that your brain is perfused, or make sure your oxygen and nutrients in your bloodstream get back up there at an appropriate rate. And so you can have all different types of conditions that fall underneath dysautonomia. And what we'll probably talk about more today is how they are all shades of gray of the same thing, of the same systems in your lower brainstem. And why what we do in our office ends up helping patients get better faster than your typical more popular protocols out there.
Mm-hmm. I do want to, touch upon one thing, which is that there is actually data in rheumatoid arthritis where we know that if we stimulate the parasympathetic system, there's more healing. Mm-hmm. And they actually have a FDA approved stimulator of the vagal nerve that is FDA approved to treat RA, which I find fascinating because I'm like, well, I'm pretty sure there are other ways to activate the parasympathetic system.
Yeah, there's a bunch of simple ways that I could bring them up today. First and foremost, but like if we talk about arthritis, what is that? It's the immune system gone wrong, right?
Out of balance. That's how I like to call it.
But if you talk about it, and if you start thinking about the immune system from a neuroscience perspective,
totally,
where does the immune activation come from? You can have pro-inflammatory cytokines, you can have neurogenic soup in the joints themselves that can create some localized inflammation. But a lot of the inflammation, like when you think of where it comes from, specific structures in the brain activate to release specific parts of the immune response. And so it all has to, like, the proprioceptive feedback that you get creates a change. So like I've worked with patients like trigger finger, where they have what looks like an arthritis in one joint, but then we start working on proprioceptive awareness of that area, not from, hey, let's move the arm, but from a brain perspective, and then all of a sudden it'll clear up.
Yeah.
So it's kind of like, and this is a lot of what you do as well, which is if you dig deeper, you're able to actually uncover more and get to the results instead of saying, oh, well, you have this diagnostic title, then I'm going to throw that away and just give you treatment A, B, or C. And if those don't work, I don't know, when it's better just to say, let me do a good, thorough exam. If I have a good idea of what's going on in the body, then I can have a really good idea of what to do for treatment that can change with the patient instead of hoping that the patient responds well.
I love that. I think that's funny. That's actually where we're at right now, which is you're like making an educated guess of which treatment is going to work the best. And then if that doesn't work, you have to switch to another one and then to switch to another one, which I do very fast because I think that we need to get our patients in remission as fast as possible. The thing is that while there are patients that are going to respond right away, the question always to me is, why is it not working right away? Then it's not just a cytokine issue. It is, there's definitely something underlying that we need to go and uncover and figure out. So what I love about what you're saying here is, we talk, and it's just such a key word now, mind-body awareness, right? Mind-body connection.
Overused.
It is a little, it is overused. And at the same time, I think it's super important. And so there's this balance in my head of saying, look, I don't think that we create our disease. I think that that's putting way too much guilt and it just doesn't help us to see it like that. And I don't think that that's the case. There are genetics, there are environmental factors, then, COVID has created a lot of POTS and a lot of dysautonomia, for example. But it is really interesting because you are mapping the brain and being able to share, like, look, if we activate this brain part, then there is this issue on, the joints, for example. Can you talk to us a little bit more about this? Because that is exactly what we could call the mind-body connection here, right? Which is not at all what people think about when we say that.
So anybody you talk to, whatever they like the most always becomes the most important part.
Yeah.
And so you can have a mind-body connection, and they always talk about the mind creates changes in the body, and now there's a whole profession becoming somatic therapists where they do things that are, again, based on diagnostic or based on an assessment idea. Then they give a prescribed or pre-designed treatment option, and it's still not individualized medicine. It's more individualized than everybody gets one pharmaceutical, but it's less individualized than you can really get if you understand the systems underneath. So if we think of the mind as an output of the brain, then if we improve the function of the brain, the mind should improve as well. This is why a lot of the side effects that we get from the treatment we do I had a patient that that responded. She said, after 6 weeks of working with you, my anxiety has improved more than 6 years of working with my therapist.
Mm-hmm.
And we weren't going after her anxiety.
Mm-hmm.
We were going after dysautonomia type symptomatology,
Mm-hmm.
dysautonomia pathophysiology, which is pathophysiology for people who are listening. Pathology is disease. Pathophysiology is a normal function that may be behaving abnormally.
Mm-hmm.
And so for this patient, she went from, in her words, feeling like her anxiety was a car accident every day to losing her pencil every day. So the whole idea is from this mind-body awareness perspective, that's great, but let's figure out actually what creates the consciousness that is the mind. And then if you work on those systems, then all of a sudden your brain can respond better to the world. If the sensory information you get, sight, touch, sound, taste, and this other really important system that's happening all the time called your vestibular system in your inner ear, which for people who don't know, that's how you measure where you are in relation to gravity. So you know which way's up.
Mm-hmm.
And when you move through the world, you know that you moved through a gravitational field, as opposed to you tilt on your side. You're like, am I up? Am I not? Those systems all provide your brain information. So imagine if you were driving a car and in that car, you didn't have windows, but instead you had TV screens and you had cameras on the outside. You would be dependent on those cameras for telling you where the world is, where you are, and everything else in between. If those cameras are skewed, then you're going to have skewed information.
Mm-hmm.
If those cameras are lagging, you're going to have information that's outdated. And so for a lot of the patients that I end up seeing, I find that those are the systems that allow you to figure out where you are and where the world is,
Mm-hmm.
aren't as accurate as they need to be. So your brain can't interpret the information as it should. So your brain can't respond. And the response that you're going to have is some sort of, the term is called efferent pathway for anybody who's
Mm-hmm.
listening. It means it's an output of some sort. The output is usually psychological or motor. However, that output doesn't necessarily mean it has to go out of the body. Output can go to your frontal lobe and create a conscious experience. Output can go to your frontal lobe and create the conscious perception of anxiety. And so one of the things I really like to share for people who are dealing with dysautonomia or POTS, one of the things that I've yet to see somebody who doesn't deal with this, simple overstimulation causes an increase in their symptoms.
Yeah, absolutely. Which is why it's so hard. Because some people are like, well, just exercise. And they're like, no, actually, if you have dysautonomia, you don't want to just go. Because then that can actually create like worsening of your symptoms. So yeah.
Now,
Yeah.
the leading researcher in the field, his theory is that basically the decompensation and the deconditioning that all these patients have because they can't move
Mm-hmm.
is the cause and the issue. So if you do recumbent exercise
Mm-hmm.
for I believe it's 6 to 9 months, then you can
Yeah,
have.
but slow, right? It's you can't go like,
But the reason
you used to rock climb, now go back rock climbing, and then their heart rate goes. I mean, the number of patients that I used to think that after COVID, when this was there, dysautonomia, you're like, oh well, let's just get you into a coaching program with I'm thinking of a rock climber coach, and I remember like talking with them and being like, okay, something is different for patients with dysautonomia, at least from the COVID, right? But I find it really interesting because, this is the issue, is that suddenly they're like, well, I don't want to exercise at all. And you're like, no, that's not good.
And there's actually a whole paper on why
Mm-hmm.
people don't want to exercise if they have dysautonomia, because they don't feel good.
Exactly.
And it's not chicken or the egg. It's
Mm-hmm.
clearly they have dysautonomia, so they don't want to exercise, creating deconditioning.
Mm-hmm.
If you work on the deconditioning, you're still not going after the part that is why they stopped working out to begin with.
Exactly.
And the studies show for this particular protocol, 71% of people who complete the protocol have some sort of improvement. But I believe the dropout rate was like 59%.
Yeah, that's a lot, yeah.
And so if you're talking about 41% of people who actually start the program are even able to complete it, now you're talking about a percent of a percent that can actually feel an improvement. And you know what the worst part is? And this is my biggest frustration with this particular protocol, because it's really good for when it's used. And I've worked with patients, got them able to move again and able to actually tolerate exercise. And then I put them then I have them go work with somebody do the protocol, and then they complete it successfully. And then they feel great. But the issue is, for people who have that as their first recommendation, they lose hope. They lose confidence because of the way the protocol is expertly designed. Is from a research perspective, it's not well designed for individual humans going through a system. And while I would love for that protocol to be utilized more in proper context, because I think you could have like great effects. Now, here's the thing though, but let's say you work with these patients. How do you get the patients who are bedridden? How do you get the patients who really can't handle sitting up? How do you get the patients who are struggling day to day? And we're talking about that, even that simple overstimulation part. Understanding the pathophysiology of dysautonomia, whether it's from post-COVID, post-concussion, other illness, autoimmune, understanding the complexity of those situations, you can make some really fast changes. We're writing up a case study from 2 weeks ago. We had a patient come in from Ohio. She was pushed in a wheelchair because she's shaky when walking, and she doesn't feel confident going in and out of buildings, especially new ones, and she'll have panic attacks from that. And what we did is a lot of work with her visual and vestibular systems, but not vision therapy, vestibular rehab, isolated in silos of, okay, you can't move your eyes back and forth. Let's move them back and forth over and over. Oh, you can't tolerate turning your head back and forth. Let's make it move fast. Instead of a habituation type therapy, which is typical for most of the industry, which works well in the context of, for things it works well with. For these kinds of super sensitive cases, doing more of a corrective approach, where if they can't move their eyes from right to left, but you see that they have something called a hypometric or a hypermetric saccade, which is when the eyes, instead of following along, they fall behind and jump to keep up, or they rush ahead and jump to come back.
We see that in stroke due to the vestibular,
Exactly. But here's the thing. If we're not going after those particular errors and we're just saying those are normal findings and we're just going to do regular things on top of it, now we're training the brain to say this is a normal way to view the world. That can create a headache. That can create a dizziness. That can create a symptom that people have. And it's not necessarily that other people are doing things wrong. It's that sometimes cases and patients need that deeper detail to be looked at to make sure that other things aren't being missed. And so this patient went from a wheelchair on Monday to walking in with some mild support from her husband on Thursday to walking in and out under her own pressure under her own power on Friday. We're talking about an 85% improvement as reported by her in 5 days. So where I like to work with these cases is understanding that those parts of the brain, like I said before about the overstimulation, that is a pathophysiology where when your brain can only handle a neuron, depending on the size and depending on how much chronic local inflammation there is, or depending on whether or not there's a hypoxia going on or a lower oxygen environment due to a number of reasons, your neurons only have a threshold that they can fire underneath. If they fire beyond that threshold, if their action potential fires faster than their metabolic rate or faster than they can handle, they pop. And what happens is it creates this thing called glutamatic cytotoxicity, which drives the area in which it happens, which basically means that depending on what structure in the brain it is, that will be where that symptom is and what symptom they feel. If it happens in the nucleus tractus alterius, in the lower brainstem, that's the conscious perception of nausea. If it happens in one of the vestibular nuclei in the pontomedullary junction in the back of the brainstem, there is where you get could be some sort of vertigo. And depending on which system it is, will tell you how it feels. I've had so many patients that come in feeling like, and have described, I have dizziness and it feels like it's in my legs. It's a vestibulospinal tract reflex coming from the lower vestibular nucleus.
How do you fix that? How do you
rehab it? So you have to start with the systems coming in and making sure systematically one at a time,
But
that you can actually evaluate and treat. Now, to fix something like that in particular.
Yeah, for example, let's take that one. Yeah.
You have to find a way to get into, there's 4 nuclei, we're going to shape them like a diamond. So the 4 nuclei, the lower one creates output to your vestibulospinal tract. For everybody, what that is it's coordination of from basically neck to hips and everything below in order to be able to walk.
But so I'm trying to put, so there's a ton of science, and then there is how I'm imagining from what you're saying also what chiropractor work is. How do you put those two together? Because how do you rehab those nuclei?
So here, the way it is it's honestly, it's not even a chiropractic thing at this point. It is it's brain rehabilitation, neuro rehab.
Got it.
And at this point, what we're talking about is reflexes that the brain has. So you have all these reflexes, like something called the vestibulo-ocular reflex. So every time you turn your head one way, your eyes should move equal and opposite the other way. You have a cervical-ocular reflex. Every time you move your eyes one way, you get muscle activation in specific patterns based off of which direction your eyes move. There's also a vestibulo-cervical reflex. Every time you turn your head, you create a reflex in the neck as well. Or every time you, let's just say, turn your body.
So you're asking your patient to move their head depending on how you're seeing their saccades.
Correct.
Depending on what they're doing.
And depending on the type of stimulus you provide, you can create a stimulus to a body that they can receive, and it'll hit a circuit in the brain and potentially in the body that will create better, essentially better awareness of where you are in space, so you can actually respond to things well. So the whole idea is, it's not like just like, oh yeah, you do this exercise and it does that one thing. For most of our patients, we got to figure out which of those reflexes are the right window in. And when we use that right window in, then we're actually able to make some pretty fast changes with patients.
So I cannot not think of our last guest, Dr. Tom Frist. He's a PhD and a researcher in Germany, actually, and he works with brain function and music. It's super cool because he has like this device when someone is, so he was explaining this, when someone is, for a long time in bed and suddenly you're trying to put them up. And it's a device that's going to have this music that's moving, the rhythm changes as you're going up. So instead of being stressed, having their heart rate go up, they are actually able the patients are actually able to handle it a lot better than ever before. So I'm thinking between what you do, between this, right? Because that's a real issue. Like being able to get up is a big issue. And I love this idea of rehabbing the brain in a slow fashion so that we don't overdrive it, basically. Yeah.
So it's funny because from what I use isn't necessarily a specific treatment.
Yeah.
I use a paradigm that allows me to use a framework.
Yes.
Within this framework, I can use any stimulus. And so I will use music with patients. Because there in the research and the literature it shows that minor keys versus major keys will change which parts of the brain you stimulate. Left brain versus right brain. Depending on if the beat itself is a slower beat or a faster beat.
Yeah.
There is attunement, I feel like is the wrong word here, but that's what I'm thinking of right now. There is frequency of firing in the brain, and every single structure in your brain has a frequency of firing. For example, your cerebellum is 40 hertz. You can use music at a specific frequency to help stimulate different areas. There's the same thing with just vibration in general. Like vibration plates, there are different vibration frequencies stimulate different areas of the brain. Now, what's fun about the music, though, is we'll use that a lot. Because when we're talking about, remember I was talking about how like overfiring of a certain area creates the symptom. If you have overfiring of a couple of areas in your frontal lobe, orbital frontal cortex, dorsolateral prefrontal cortex, prefrontal cortex, ventral median prefrontal cortex, those areas overfiring, and sometimes with the amygdala as well, will create the conscious perception of anxiety. So when I have a patient that comes in, I've yet to have a dysautonomia patient that didn't have some sort of anxiety.
Absolutely, yes.
Why? Because
the feeling.
Not just that, but forget the mind. Move the mind out of the equation for now. Bring it back in when it's appropriate to. But if we look at the brain as the generator of the mind, now we can say, hey, when we have overfiring of the brain, that's swinging back and forth like that dysautonomia, swinging sympathetic to parasympathetic. When you have that swinging, overfiring, underfiring of your frontal lobe, now you're also getting the conscious perception of anxiety. Yeah. It's not just that my life is falling apart and I'm stressed out. It's that your brain is overfiring in ways that needs to be brought under control so it can be managed. One of the exercises that we use with a number of our patients, again, individualized to the patient to make sure it works, but tapping. Typically, I have them cross their arms over their chest and tap alternating.
Oh, that's EMDR, yeah.
It is, except EMDR is is so frontal lobe intense that we'll find that a number of our cases will try that, fail that treatment, and they'll say that it made them feel worse. I'm like, yeah, because your frontal lobe can't handle that stimulus yet. Yeah. You have to work on these other systems that your frontal lobe. So
you're adding a little bit of it. Yeah,
we're adding just enough to create a stimulation, because it's not even the frontal lobe that we're targeting. It's this thing in there called the basal ganglia, which is by far, in my opinion, the most important part of the brain. It's your error processing system. It's also your gas pedal, brake pedal. Think about people, they ramp up mentally. They really slow down mentally. Your basal ganglia has that gas pedal, brake pedal, and your frontal lobe is intimately tied in with it through 3 individual pathways where the wind up will happen. I'm sure you've worked with some people where they're talking and all of a sudden they get on this emotional kick and they keep going.
Yep.
That is pathophysiology in real time. That is your basal ganglia feeding back to your frontal lobe, creating
How do you block that
wind up. What?
How do you block that?
So you have to go in, you have to first work. So from the basic approach that I use is I start working on cerebellar and brainstem reflexes and how those work. Because if there's errors in those systems, you're going to go to your error processing system, which is the basal ganglia. So if you're going to reduce the overfiring of the basal ganglia, because it doesn't have to continuously error correct, you can now have more accurate cerebellum, brainstem related things. Now, if you really dive into the literature and you learn it, then that's not exactly accurate.
It's okay. Yeah.
But the whole concept is, if you can get the cerebellum and the brainstem to start working more appropriately, now the load is taken off of the frontal lobe basal ganglionic system, so that way it doesn't always have to jump in when it's tired of doing its own work, say now I have to do their work as well. So to break down that, to block that, like you said, that's why I give that exercise, because it starts to train. Because if you give a rhythm that's slow enough, and I use 40 beats per minute because it's easy to remember, easy for people to do, and it's slow enough where they have to inhibit that. We just need a tap, especially for the people who are winding up. You're training the brain to be able to sit and wait and react, because the more prediction that your brain has to do, the more coping mechanisms that you have to teach your brain to use, the more it has to do, the more it drains your energy systems. And what you need to do is you need to train your brain to just react appropriately on its own, instead of needing all of these overlaying cues or strategies to create an environment that allows it to succeed at its weakened state. Let's just strengthen it.
Love it. I love this. I think that's really powerful. If there were one exercise or 2 or 3 maybe that you could share with our auditors that may not be able to work with you just yet, maybe they are outside of Colorado, what would those be?
Okay. So let's say they are bedridden, because we do get people flying in to work with me. If they are bedridden and they are unable to move, and they are having a bunch of issues with it, one of the main exercises I do, now it's better to be done passively instead of actively, because those are 2 different pathways in the brain, but passive head motion. So it's called gaze stability. So you're essentially stabilizing your gaze, your eyes on a target, and slowly moving your head. Now, as you can imagine, this is the brain, so it's a lot of little nuances to it, and I'm going to try and share as many as I can without overloading people. You need to keep your eyes on a target. That target has to be further than arm's reach away. Arm's reach is fine, but it can't be closer than that. You don't want your eyes coming together to this exercise, or you can make things worse. So if anybody's doing this exercise and they're like in your face within arm's length of this, please ask them to move back a little further, because it's going to make you feel better faster. The second thing you have to do is, since the target is stationary and your head is the thing that's moving, you want to first make sure that the target is eye level. Not most people set it up just their thumb out or their thumb at the tip of their nose. I want it eye level, because you want to start in a neutral plane. The third thing is the head turns have to be slower than 30 degrees of rotation per second. The reason why is because 0.08 hertz is the velocity turning the head that can create a vestibular activation. There's a treatment move called a Amigues head thrust, which is, I believe Dr. Amigues is a neurologist, where you move the head quickly to one side. Now, it's not a whip. It's faster than that 0.08 hertz to create velocity potential to get activation. If you're doing this exercise, you need to move the head slower than that 30 degrees of rotation per second. And if anybody's curious, 30 degrees of rotation is going from 12 to 1 on a clock. That's 30 degrees, slower than a second to get there, because you don't want to load up and create a bunch of vestibular input. You want to start by working on that cervico-ocular reflex and get that to be as accurate as possible.
And so when you're saying it, like ideally you would like it to be passive, is that someone is actually moving their head?
So somebody else slowly turning the head side to side.
I think that's actually very cool. That is totally doable.
It really is. This is very straightforward. People can do this. And this is what we start with when people come in. We start with, as long as this is the appropriate thing to do. Again, there's always nuances. Not everybody can do that. If you can't do it, it doesn't mean that it's the wrong exercise. It means that it's the wrong exercise right now. It means that there's probably something else that has to be looked into, some other system that needs to be worked on so you can do it. That's something to think about. Again, a lot of these exercises are nuanced. They are targeting the area that is weak, which means if we're targeting a weak area, that means that there might be a little bit of failure in there. But if we're doing it in appropriate doses, and if we're doing things strategically, and if we're doing things mindfully and aware of what's going on with the patient, able to see changes in their neurological system, then they shouldn't feel worse before they get better, or they shouldn't be exacerbated, at least, if that makes sense. So passive head turn, slowly on their back, lying down, throw a dot on the ceiling of some sort. I like to use high-tech things called sticky notes with a Sharpie, make it a dot the size of a nickel.
Super high-tech.
Throw that everywhere. Make 30 of them, and throw one right above like a couch, a bed. If you got a massage table there, they're like $80 on Amazon. You're just sitting up there, and you're just gonna have somebody slowly turn their head side to side. Now, only go 20 to 30 degrees side to side. We don't want to make it so you can't see with one eye. Yeah. Slowly start with the middle, and then we progress it and get it better as you can do more. If I had to give one exercise for
love that one. I think that's super helpful, and I'm intrigued. I don't have dysautonomia, but I'm really intrigued at it, so I'm going to try. I think that's really, really cool. This is where I start with
all brain cases, whether they're just focus, brain performance, whether they're I've a couple of movement disorder cases, like cervical dystonia, where neck stuck like this. This is kind of where you start, because if you can't, and this is why, because in the evolution of the brain, there's certain things that develop before other things. Your vestibular system is something that develops so far ahead of other systems that it needs to be accurate, because everything depends on it. It's the system that everything is plastered on top of. So if you don't have your system that allows you to figure out where gravity is, and if you don't have, and then you have that basal ganglia, which is the crude motor pathway, and your thalamus, which is the crude sensory pathway, you have sensory in, motor out, and something that just tells you which way's up. And then it gets more and more complex through higher life forms, and you get more, and then with humans, we get even more complex. We have all these little structures that we can work with and figure out which ones need the the push, which ones need to be pulled back.
Mm-hmm.
And we can do that by knowing what inhibits what stimulates what, which things are always firing, and which things need to be pushed to fire. So it's putting it all together.
This is awesome. So I'm pretty sure by now a lot of people are like, well, I want to know where I can find this dog that's going to help me. So where can people find you?
Absolutely. So I am in Denver, Colorado. We have 2 offices here. We have my business partner, Dr. Carly Hudson, who's off of I-25, and then I'm in Golden, off of I-70.
Mm-hmm.
We do neuro here in our office. It's called Delta S Performance. That's our specialty. However, if you have any questions, we offer free 30-minute consults to anybody who's interested, even if they just want to ask questions. Go to our website, click on the Get Started form, fill that out, and you'll be put on my schedule relatively quickly. And we're going to hop on the phone call and we're going to chat about what you might be dealing with. Now, on top of that, on my website, because this is a real dysautonomia is real. While I'm happy to work with anybody, I've had people as far as Kuwait and Saudi Arabia come in to work with me. While I'm happy to work with everybody, not everybody has the means to travel around the world to seek out care. I have a website. On my website, there, under resources, I have a map. On that map are people that I have either personally seen practice and say, yes, if I was in the area, this is who I would go to if I had this issue, or they are similar enough to me where I'm like, yeah, you're going to get good stuff. Because the problem with, and you probably see this as well often, the cool thing about hospitals is there's a standard of some sort. The minute you get out of a hospital system, a lot of it is artistic licensure, if that's a way to put it. And so for some, that's really good because people really go to the next level and do a lot. Some people just buy a lot of technology and throw a lot of therapies at people and charge them a lot. And so I just want to make sure if somebody listens to this and they hear this and they want to have this kind of care, my website have a list of people who do it similarly, and you're more than welcome to call me and chat. And I can point you to some people in that area if there's nobody in your area.
Well, that's wonderful. Thank you so much. I think this was really passionating. I have the French word. Very interesting episode. Thank you so much. Like all of the science, I mean, clearly you're super excited about it, and you offer a ton of improvement for your patients. So, I jumped in on getting you on the podcast because it's a real need. This is a real need, and I don't think that Western medicine has a lot to offer. In fact, I think they have very little. So, very excited. I think you're going to be maybe very, very, very busy from the rheumatology world, at least.
Well, happy to help. And also, because a lot of the stuff we're looking at, we also work with brain neurochemistry from a functional medicine standpoint. So gut-brain axis, it's not always working on the gut only. Sometimes you got to work on the brain. You have, like we talk about vagus nerve stimulation. That was one thing I wanted to make sure listeners heard. If you're grabbing a vagus nerve stimulator, do it on the left side. If you do a vagus nerve stimulator on the right side, especially if you're already a sensitive patient, you can give yourself an arrhythmia. There's risk of that. We don't want to give ourselves arrhythmias.
I don't think that I'm someone that is going to recommend a vagus nerve stimulation when we have so many other ways to stimulate our vagus nerve.
And
I'm really like
gargling water.
Exactly,
that's
like
great. Singing at the top of your lungs. Deeper voice. You can even just like grab your toothbrush, and I'll give this to some patients if appropriate and needed. Just tap the back of your tongue with your toothbrush because your gag reflex is vagus nerve output.
Exactly.
These are many ways you can get vagus nerve output. And the problem is we have to go against individual companies who make the stimulator.
Exactly. And making money. Yeah, that's okay.
And so when we talk about that, then the idea is I'm not going off, and I don't think that there's like a big vagus nerve stimulator by any means. But if you're going after that, like if you're listening to this, just like left side.
Left side. Yeah. Well, that's wonderful. Thank you again so much for being on the podcast. And I'm sure we'll have you come back very soon. So, yeah,
Happy
it's
to
been a
talk.
pleasure. Thank
Absolutely.
you. Well, thanks again for tuning into the UnabridgedMD podcast. Be sure to subscribe so you can be notified when the next episode is up. And as always, if you think that this would be helpful for a friend or a family member, please share. Wishing you wellness. Until next time, take care.